All right, we're back with another PCBH Corner. I think we made the same joke last time that this is starting to become like the host of SNL of
That's
how
right.
many times that you get to be on it. But this is your third time, Deepu? Is this third or fourth?
Third
Third?
or fourth, maybe. Yeah.
Yeah, yeah. We
Yeah.
gotta get a specific count. But as I'm so excited to welcome just I don't what's very interesting. I usually will say, and when I talk about you to other people, it's just you're one of my favorite humans, and it almost doesn't seem like it in encompasses actually what that means. So I
Uh,
would just say one of my favorite spirits of being able to
mm.
integrate and to talk with is Deepu George. Deepu, do you want to give, for maybe those that might for the first time be tuning in, might be new, just a little overview of who you are, your professional background, where you're at right now?
Yeah. Man, this is such an honor to do this because you and I know this is the work that we care about. So to be able to talk about it's amazing. I am a associate professor of family medicine at the University of Texas, Rio Grande Valley School of Medicine. I work in the Department of Family Medicine, been practicing and learning PCBH every day for the past 10 years. Most of my working life and waking hours are spent on this thing. So this is kind of the air that we breathe and things that we do. CFHA is a big home for me. That's how through Patty, I met Dave and Bridget, and that's been very helpful. Um, I do a lot of training. I do a lot of thinking around PCBH and how to train future physicians and mental health providers to do what we do, right? And I think there's just such an evolution in that understanding the more you live into a truth, right? Like the more we kind of wade into the waters, the more we begin to allow that process to shape us back. And so I would say that's where I am in my understanding of PCBH. Totally related or maybe unrelated in another part of my life, I'm in theological training to be ordained as a priest in the Episcopal Church. And so that's another thing that's like floating in the background that I'm engaged in all the time. So that's kind of where I am.
Deepu, want to just, I don't know, I just always appreciate these moments. And real quick, Deepu and I were joking. I am not in a hostage situation. I'm in Seattle right now. We were trying to figure out the lighting situation, and now I'm looking at my camera. It's like, it doesn't look good. And I have this beautiful view of the city and of the sound, and the sun's going to probably come, so it's going to mess up everything. But that's okay. That's okay. But, Deepu, I'm reading a book on the Dalai Lama, and I'm trying to think it. I'm embarrassed to forget the guy's name.
Desmond Tutu.
The Book of Joy.
Yeah, the Book of Joy. Yeah.
Oh, did we already talk about this?
I don't think so, but
How the
I
hell did you know that?
because Desmond Tutu is one of my, well, both of them are two major spiritual icons for me. And Desmond Tutu's reconciliation theology is something that I deeply identify with and I think about as a basic framing to engage the world, both from like a living out the witness of love perspective, but also
Hmm.
from a moral perspective. So I think he really charged up the apartheid work that he did and
Hmm.
um, moved South Africa through a very meaningful reconciliation process, right? And then the Dalai Lama. So I have my wallpaper changes like every 10 minutes. And several of my wallpapers are these candid shots of the Dalai Lama and Desmond Tutu just laugh.
Yeah.
And so, yeah, so they're two
I
of my favorite.
love I love so much that you knew exactly because the book has been profound in so
Yeah.
many different ways and honestly as I usually listen to it as I'm working out in the morning and I think about you regularly and I
Mm,
think this will be something that we will talk about today and a couple different things that stand out. One about service being joy and how
right.
that can produce,
Mm,
and then the other thing about it being this idea of connection that if we don't have this human connection with another sentient being or another individual that joy is almost impossible to be able to occur in and so I don't know I just have always appreciated you bringing this spirit and this joy to the
mm.
work and the honor that we oftentimes forget that we get to do with the service. So let me ask you this. One of the things that Deepu, Bridget, and I we've been doing a lot of group chats about, and really started as it always does at CFHA, and then just continues to linger outside of that and ripple outside of that, is this idea of making sure that we see people within their context that we're talking about, and whether that, via the CI and using things like Access V to really prompt mental representations. And the one thing that I really appreciated you bestowing on me was this idea of like cultural intelligence, this
Yeah.
idea of honing in and try to be curious about that. And I know you want to show kind of a different way of, I don't know if it's a different way, but a way of looking at this and this iceberg of this. So I'm just going to pass over to you. I'll probably prompt you with some questions of different things. But yeah, where's your mind go just right off the top?
Yeah, so I think part of what we want to think about is like, we all come with baggage, right? And so part of our task is to be aware and manage the baggage, right? And part of that is like the conditions and or the conditioning that we have been through. And so that's where I kind of want to begin thinking about cultural intelligence. And I've been toying around with like the difference between intelligence and wisdom. And
Ooh,
like
ooh,
intelligence is like, it's like
ooh.
very hierarchical, merit oriented kind of a thing, whereas wisdom is actually much more nuanced than that, right? And so
Mm.
I'm going to use intelligence probably, but probably I want to use wisdom. So let's see how that goes in our conversation.
Ooh, I
So
like that.
yeah. So one of the things I was thinking about when we talk about cultural humility, cultural intelligence, whatever it might be, how are we really labeling what is a culture, right? Like, and so
Hmm.
I found this very helpful model. And this is like, I'm surprised, like, this has not been in my training or conversations anywhere in my like when I was getting trained. So this was like something that was developed in 1976. So this is not like new. So this is pretty old stuff. So he talks about, Edward Hall talks about there is 10% of culture that is visible, right? So these are like food, language, fashion, literature, arts and crafts, things that we identify. And I think a lot of our assumptions that we make about people is based on like the 10%
Hmm.
that is visible. And that's above the waterline, right? So a lot of the things that we think about in cultural terms are these things that you kind of see on top of the iceberg right there. But then below the waterline is actually deep culture, right? These are styles and rules and notions of courtesy and manners and
Hmm.
cleanliness and friendship and leadership, concepts of time and fairness
Hmm.
and justice, and then
Hmm.
attitude towards elders and adolescents, independence, rules. And you talk about like rule governed behavior, like a lot of
Hmm.
that kind of I would imagine comes from these deep-seated things that we are exposed to, but we're not
Hmm.
really kind of aware of all the time. And then beneath that are like things around religion and courtship and marriage and problem solving and all of that. And this ordering is kind of artificial. So I don't want to kind of say religion is at the
Hmm.
bottom and communication is at the top, but there's a lot that goes below the waterline that we often don't think about or are in our purview when we talk about cultural wisdom and being able to bring that into conversations and other things. And this values plus identity, that's something that I thought about. So I was reading through this and kind of getting some training on this. I thought when we think about values, when we discover values that are kind of like the internal appetitive drivers for human beings, I like to think that it's nestled somewhere in between all of this, right?
Hmm.
So in a
Hmm.
in a in a CI, in a consultation visit, when we are really pulling something out with the patient of something that they value, I think it is soaked in all of these things, right?
Hmm.
Regardless of who you are, right? And
Hmm.
so part of our task is to be able to be good at that, to be witnesses to the deeper parts of people's culture, right? And you know, the values and identity piece also makes me think about growing up in a multicultural society like the United States. I imagine we have multiple cultures that are kind of influencing our lives, whether we are aware of it or not, and therefore there are multiple identities that might be possible, right? And so
Mm,
it's not like static, it's kind of
mm,
dynamic, and we know as developmentally as people go through their life cycle stages and other things begin to change and percolate in different ways than maybe when they were like 13, 14, 20, 30, right? Like as people age, hopefully they're kind of changing. So our identity markers, yours and mine, with our patients are always in play. And that could be a number of things, right? Like the most visible things that we think about are like race, gender, those
mm,
kinds of things. But there is socioeconomic status, like your ability, your are you abled or differently abled, right?
mm,
Like how are you thinking? What's your emotional kind of rules around behavior and engagement? So all of that is, I think, interacting in a visit when we sit with patients all day. So as I thought about more and more about operationalizing
mm,
what does this look like, right? So how
mm.
should we think about it? So at least the three components that I've kind of like come to, and so this is where we can kind of rumble and you can put you can push back or add and put some depth to it, right? So I thought cultural wisdom, or if you want to use intelligence for now, you can, is the willingness to remain humble throughout the interaction, suspend any interpretation, and commit to moment curiosity.
Mm.
So
Uh,
to me, that is, it's dynamic, right? Because the deep part of the culture, like the below the waterline culture, is dynamic, and therefore cultural wisdom also should be dynamic as we enter into it. And the agency that we take to create a psychologically and emotionally safe space is cultural wisdom, right?
mm,
Because
mm,
everything that's underneath requires some amount of safety
mm,
for the other person to risk their safety
mm,
to
mm,
to be honest with you, right? As when you're kind of running a visit with them. So it makes when you're able to do that. So part of our wisdom, I really think, is just about every interaction that you walk into, can you um, verbally, non-verbally, by just your mere presence and the stance that you take, can you create and engender psychologically and emotionally safe space so that growth can occur, risk taking can occur very easily. And so the end
Deepu,
result, yeah.
can I pause you real quick? This is great, and my mind's going so many different ways. Real quick, the three things that you said that made up the cultural wisdom: willingness to remain humble, suspend, and what was it again? Suspend
Interpretation.
interpretation. Okay, and then the moment-to-moment curiosity.
Yeah, and a commitment
Okay,
to moment curiosity.
that good word. So let me ask you this, and you might have been going to this way, so I apologize for interrupting you with this. So, I was given a recent, and here comes the sun. The sun is coming up. That's nice. So I was given a recent MI lecture to medical students and residents, and I'm interested to see the feedback because the one thing that I said to them at the beginning, I said, hey, I'm not giving you skills to weaponize MI. Like, I'm not giving
Mhm.
you hey, this is what to say, this is what to do. So then you guys just go into the room and you just do these skills
Right.
without understanding like the spirit, not understanding like the position, the stance almost of this. It's like, we're not doing that shit. So it was more just like philosophy, just different kind of things. And again, I have no idea if anybody left anywhere with it. So the question that I have for you, how that stance that you described right
Mhm.
there of having a willingness to remain humble, to suspend interpretation, and to commit to moment curiosity, what produces that in
Yeah.
clinicians? Like what allows clinicians, what allows you to do it? Where does your mind go? I know that's a big question. I don't even know if it makes sense, but where does your mind go with that?
Yeah, I can try to like think open with you about that or think out loud with you. I mean, so let me be clear, right? Like this definition is it sounds very ideal, so I want to make it clear that I probably don't hit it 100% all the time, right?
Hmm,
Because we are
hmm,
human beings and
hmm,
therefore we are prone
hmm,
to the errors of judgment. We are prone to bias and other things and in frustrations and the busyness of the day and all of that kind of stuff, right? So I just want to be clear.
And wouldn't you say that awareness piece
Yeah,
of us being human goes into almost like reinforcing those three tenets, because that one shows humility,
yeah,
that also is like a stimulus controlled, like pause, make sure to
yes,
not interpret, and that constant curiosity, like that awareness piece and that belief in that almost produces
yeah.
those three things. Yeah.
So that's one thing I think about, right? The other thing and you and I and Bridget have talked about this, right? Which is, and we need to develop it further probably. I think about how are you embodied uh in everything that you think and believe. Like it's almost like
Hmm.
if you kind of take clinical training skills and competencies as kind of, let's say, motorized skills, right? More or less, like you can recall, identify, target, label, and then based on this cognitive operations, you then are able to say the right thing, guide and nudge the patient the right way. So I think that's one level of competencies that we talk about. I uh, one of the things I'm fascinated by is by providers who are willing to go a level deeper, where you're using your embodied sense, like your somatic sense of what's happening in the room, to titrate the kind of work that you do in moment to
Hmm.
moment, right?
Hmm.
So I think in CI and Access we talk about the willingness to curb the urgency to intervene,
Hmm.
right?
Hmm.
We don't want to actually over
Hmm.
interventionalize the visit,
Hmm.
because then you're probably preventing something that could be relational and not transactional, right? Because when you're just kind of really focused on that SMART goal at the end of the visit,
Hmm.
it could become very transactional, right?
Hmm.
Like you're kind of like providing the right prescription and the right kind of materials. And I'm not saying that's not useful, right? Like I just want to be clear about that. But I think there's something
Can I
about,
pause you? Can I pause you real quick?
yeah, yeah.
Because I almost want to just see, uh, why do we have to apologize for that? Like, why, almost
Oh
like,
yeah.
why do,
Let's get
so this is the thing. I really, I would love to know where your mind goes about this. Like,
yeah,
what
yeah.
is the relational frame where there is this like constant need to be like, almost like apologetic, like, hey, we're not saying get rid of like the clinical
Yeah.
interventions. We're not saying to get rid of that. And it's so interesting because, in our field, and it is ironic, and especially within healthcare, it's like whenever we start to say, hey, do these other things like the stance, the embodiment, the spiritual kind of ness of
Right,
it. Like
right.
we almost have to again like apologize for being like, well, we don't want to give up the clinical
That's a good
interventions,
call out,
right?
man. I
Like
like
so
that pause.
I do it all the time. And Bridget and
Yeah,
I,
yeah.
we have to constantly do it. And we always have to say, hey, evidence-based medicine is paramount, all this different stuff.
Right, right,
And there's a
right.
part of my mind, it's like, excuse my language, like, why the fuck are we, why do we have to continue to do that in
Right,
a
right.
sense? It almost sets up that hierarchy. So where's your mind go?
I,
Even with that. Yeah.
I think it's just the environment that we're conditioned into, right? And I
Yeah.
think we
Yeah.
are exploring within the bounds of what might be curative in conversational and relationship, but outside the bounds of like what people might label as very rational ways of thinking through
Hmm.
things, like the very
Hmm.
controllable nature of uh, evidence that we think about. I mean, I think about this all the time, right? Like we're about to run we're doing a pragmatic trial in our clinic soon on like consultations in the ACT matrix, and I'll talk to you guys a little bit later about that. But I always think that's, I was like, we have no inclusion exclusion criteria, right? Like
Hmm.
it's like primary care as it
The
is,
people. Yeah. Yeah.
we can't really control that. And so I think we tend to apologize just because of the hierarchical nature of
Hmm.
how knowledge is privileged and not privileged, I think.
Hmm.
So yeah, so I think
Hmm.
kind of going back to that stance. So one is just how are you aware in the moment in a way that allows you to be present fully, not just in kind of pulling in kind of like what's running in the back of your mind as the algorithms to pull in to make your intervention or conversation work, but thinking about what's happening in the room when this patient is saying X, what is happening for me internally, right? And do I have a felt sense of what's occurring in the room? And that might invite you to do different moves than something else, right? I uh one of the things I've been toying around with recently is like interventions around emotional granularity. Like, how do we help people better become connoisseurs of their own emotional worlds, right? Like, are we so I often have a conversation with patients around what are your beliefs or things that you grew up with around emotions? Are they good emotions? Are they bad emotions? And they'll say, oh yeah, certain things are good, bad. And so how many emotions can you label? And they'll kind of give me top 2 or 3. And then I kind of invite them to say, emotions are neither good or bad. They're just like a lot of chemical reactions in our body to situations that occur. And then we kind of look at the emotional wheel and we start tracking back based on the things that we discussed in the visit to kind of help them just be good at knowing what's happening internally. Now, part of that developed because as I was trying to like teach them other interventions, right? Like self-compassion or grounding through dropping the anchor or any of those kinds of things. We presuppose that they have an understanding of like emotional states and they can kind of tap into that. And so that was one of the things that I stumbled upon, just being aware of what's happening in the room. Because you can see that they're functioning with their ability to label emotions is about this much, but what's happening in their life is just much broader. I think it's Brene Brown who she talks about language as she puts it much more beautifully than I can. She talks about like language is our vehicle to hit the shores of our understanding. Like, so if our language is limited, then our shore, you know what I'm trying to talk about, say.
Well, it's fascinating. I'm sure everybody has seen this within visits where, like words just they do not describe fully
Right.
the experience that we're happening. And you can almost see that a lot of times, even us trying to describe what we're feeling to people, and I'll call this out intentionally. It's like, man, I know, like my mind uses this word, but I don't like that because it's not like the full encapsulation of what it actually is. Yeah.
Yeah, exactly. And the last thing I'll say about the stance is, and this is like if you're really tapped into like MI philosophy, right? Like meaning you're not an MI technician versus you're like an MI adherent or believer, that everybody is moving towards their best selves all the time, right?
Amen.
Now, and what does it take you to suspend your interpretations about a person sitting in front of you who might be by all quote unquote objective standards not doing well, right? And you are now entering this room to work with this person. I think it takes incredible awareness and power to swim against everything that you've been just told, right?
Correct.
You might have been
Correct.
just told that this is a difficult patient, doesn't want to do anything, all of these things. And then if you look at their chart, the way our medical records work, it just doesn't, it really has a different function, right? It's not the function that we're looking for when we're approaching treatment. And so then it takes all this effort to believe that the person sitting in front of you is creative, resourceful, and whole. And I think, at least for me, there has to be some amount of embodiment that occurs internally for us to be in this continuous cycle of, open, connecting, and learning with our patients, and being very willing to make mistakes with them, right?
I
And being
love
open about that.
I love again that belief about creative, resourceful, and whole.
Yeah.
And you know, and again, this is where my mind obviously, because I'm sure yours goes the same way, whether it be working with residents or whether it be working with, you know, our behaviorally trained, providers. Like, what do we do to produce that? And I know that's like almost like the opposite question, like that, you
Yeah.
know, I think back to, you know, the retreat that I went into, from a Buddhist perspective. It's like you're not doing anything to other people, right? Like that's like as soon as you start trying to do that, that's where, you know, you start clinging, and then you start, you know, and this is probably why we burn out a lot of people, just because
Right.
that's our system that's built up that way. It's just one of those things where my mind just comes, it's like, it should be a requirement that there's going to be some practices, some curriculum, something that's going to connect you to humanity regularly and often in your spirituality. And again, there's almost like that same visceral reaction that I felt when we have to apologize about, like, oh, hey, it's not to say we're going to give up evidence-based medicine.
Right. Right.
Like that same thing. It's like, should there be some training of, I don't know, like humanity, spirituality, connecting those components to be a provider?
So this creative, resourceful, and whole, right? That is a phrase that I was very happy to learn as I was going through some training on like the world of like executive coaching to be a coach.
Mm,
And so the primary stance of the coach is that
mm,
you are you are dealing with a person who is sitting in front
mm,
of you who is creative, resourceful, and whole, right? So I think as BHCs,
mm.
part of dosing humanity back into the busyness that we're called into being is, are you willing to, it's almost like, you know, sometimes we assume that everybody's in pre-contemplation stage when you walk into the room, right? Like, so okay, if there are certain healthy, neutral assumptions that you can make about how you show up, you could also begin to be aware of creative, resourceful, and whole as written on every patient that you walk into.
And in my mind, it blows up when you think about how different we talked about this, I think, through I don't know if it was at CFHA or through text messages, where your stance changes in the room
Mhm.
when that's the belief entering the room.
Yeah.
Like if your belief entering into the room is that this person is creative, resourceful, and whole, that you ask questions differently. You
Right.
you respond differently
Yeah.
versus maybe a more stereotypical approach where it's like, I'm going to be the person to find out what's wrong with this person, the deficits, and then I'm going to be the person that puts the puzzle pieces together for them through interventions. And like that is a completely different, it literally changes who we become, like who we
Right.
are as providers.
Right. Right. Yeah. And if our invisible beliefs drive our behavior in one way or the other, so being able to believe this about you primarily, and the other person in that you're in relationship with, I think changes the dynamics, right? It changes the tone. Um,
Hmm. Hmm.
it changes the, I think you said it very correctly, which is it changes the kind of questions you ask,
Yes.
right? You're no
And the
longer,
function of the questions.
and the function of the question. Yeah, that's exactly right. And then you're curious about a whole different set of contingencies for this person versus being curious about how is pathology maintained only, right? So
I love how you said that you are curious about a whole different set of contingencies.
yeah.
Where and again, when we talk about like relational frames, and this is why these conversations I find so meaningful, because they're a great stimulus control for me that primes my mind to kick on different relational frames, to look
Yeah.
at different contingencies. Versus if we don't do that intentionally, it will gonna almost like naturally, because this is how our system's set up, our
Right.
contingencies are set up to drift towards this way, to see
Right.
as pathologies, brokenness, what is wrong with the person.
Right. Right.
Hmm.
And I think as BHCs, you know, maybe we talked about this, all of our conversations are running together now.
I
Um,
know.
I think one of our jobs as BHCs in the medical world, I would imagine, is to uh, in the puzzle pieces that we're trying to complete as a team on every patient, right? I think the physicians, their targeted approach to a lot of things are really looking at life-saving measures. I would argue that equally life-saving is what is the ultimate picture that we are bringing to the forefront when we're treating a patient, right? And so our job as BHCs is to bring that contextual, creative, resourceful whole view of a patient who might otherwise be labeled with a 5 or 6 labels that are just easy for us to do so, because then if we use those labels, we don't have to extend ourselves in a way that might risk some of our safety and control, right? Like, and so yeah, I think our job is to constantly go against the grain a little bit in for the sake of humanity, for the sake of believing in people's resilience.
And I love the words that you use, like life-saving, that becomes, because going back to, as you said, about the cultural wisdom and all these different things that make up these beliefs, these identities, these ways of looking at it, that that literally
Yeah.
starts to really become profound when you say even something as simple, as what we're saying, hey, take this medication. It's
Mm-hmm.
like, hey, there could be a huge amount of underpinnings, all those things are under that iceberg, that
Yeah,
if
yeah.
we're not curious enough, if we're not searching for, if we're not seeking for and trying to really understand, that simple behavior of taking a medication, like, might not ever occur, or
Yeah.
might not make sense.
Yes.
Yeah, and it really does become a life-saving aspect of healthcare
That's
when
it.
we're able to provide this.
Yes, because this takes me back to like one of my very first patient interactions that I
Mhm.
ever had. I mean, this is like, novices think of different, they're just like trying to shoot at the dark, so they might hit
Yeah.
something. So this is when I was like very new, and we had this was in North Carolina. We had this patient, and she came into the clinic. She had concerning levels of blood pressure. They kind of talked to her about it, and they came back, and then she was like now in hypertension diagnosis, and then they wanted her to take medications, and she just was like saying no to medications, right?
Hmm.
And so I was the naive young BHC in training who kind of like stumbled in there, and I just started talking. I mean, this is like back when CI wasn't fully formed in my head.
Yeah, yeah, no doubt.
I had none of that.
we're,
But I
we're just
think,
going to, we're going to throw some interventions at this person. No, no doubt.
right.
Yeah.
And so she was dressed, she's an African American woman dressed in like a gray t-shirt, black pants, and kind of like uh not very emotive, and face down. And we were just talking because I don't know what she was feeling exactly, but I remember our conversation was around like medication and what does that mean for her. And then she said, my grandmother never took a pill in her life, and she lived to her um I think I forget what age, and then her mother did the same thing. And so in my mind, I was like, oh, there is this value in her life about being healthy, but that doesn't depend on medication.
Mhm.
And so then I remember I probably said something about, um, so you value, I can see that you value your health a lot, but also this legacy of your grandmother and your mom just being able to be healthy. And I probably said something about like, I wonder how different their lives were in terms of how active they were, the opportunities to be kind of routinely like, move around, whereas a lot of our lives are much more sedentary. So, then we had some random plan around like walking to the grocery store and like just changing some things up in the routine. And so I never see this patient again, but I do hear about her from her physician. And so the like weeks later, when I was like in the grocery store, I saw her uh at like the vegetable sections picking things up. And then like months later, the physician who was treating her, she came back and she said, oh my God, so she came in today. She was like dressed in brighter colors. She was much more talkative. She had like made these changes, and her blood pressure is much better managed, and we don't have to talk about the medications again, kind of thing, right? And so I think about that because like it was just a request to start medications, but it was for her that meant something else. It meant probably breaking a valued pattern. I mean, and those are my words, right? She's probably not articulating it that way, but in my mind, I was like, oh, this is really important to her, and so that was just like that's
And
what.
Deepu, what a beautiful way of showing that it seemed like the stance within that was I'm going to search not only to see the person because that was a
Right, right,
big part of this is I'm going to collaborate with them to allow a move still that is value congruent, right?
right.
That it's like, hey, developing this awareness, like clearly a value of health, clearly a value of kind of elders and their approach to things.
Mm.
So almost like holding up that mirror, it's like, what does that mean then for us? Could
Right,
there be these other moves? And
right.
again, what a beautiful way of allowing that to show out. Like
Yeah,
that is
yeah.
can I ask you this too? So the one thing that, in this is one of the reasons why I say this every time we have you on the corner. If anybody sees Deepu at CFHA or another conference, like stop and talk to him. I know it probably annoys the hell out of Deepu that I keep saying this, and because there will be a sense of kind of joy that starts to like come
Mm,
back and
mm,
purpose, and that's why I really appreciate these conversations. And I can't help to think, you know, if we were, and I don't know why my mind doesn't like saying this. Let me know if it maybe comes off a certain way and it just doesn't like it. But I feel like that visual is like, I don't know how to say this. If we were to embrace this reality a little bit more, to go
yeah.
back to again those things about a willingness to remain humble, to
Mm,
suspend interpretation, and a commitment to moment curiosity, to get us to this, seeing people as creative, as resourceful, as whole. My mind says there's a higher probability of joy coming back to our uh space of
mm.
work, that
Yes,
we feel sense of purpose. And when we talk about
yes.
burning, we talk about like all these different things, like half of me is just like, I'm not saying all these different interventions aren't great and we should look at hours, how many things work and all these different stuff, but we're almost like setting it up that if you are like seeing your community a lot, if you're seeing a lot of patients a lot, that's going to automatically like lead to burnout, when it's like maybe that's true in some contexts. And my mind just can't help to think, if we were able to instill a little bit more joy in those interactions, it would be life breathing rather than life sucking away.
Yes. I think you're exactly right. Because I think by taking so I often think about like anything in life that is worth that is meaningful, it's often gentle, it's often softening, right? It's not like this
Mm,
hard stands that we take. Like you talk about like love, relationships, beauty, all of
yeah.
those things are gentle, soft approaches, right? So I think when we're kind of that gentle, soft in our visits, in that you bring that energy, one, you're now a permeable boundary in that interaction. And one of the things that when you guys came down here to do some training for us, right,
Mm,
at the end, I said part of our job, as if BHCs are doing their work appropriately, if we're doing it correctly, our job is to return people to themselves.
yes.
And
Yes.
then, and in return, we return us to ourselves,
Mm,
right? And that, I think that cannot happen if we maintain kind of like the role of a skeptic or an objective, kind of like we are the expert who's about to change your life, kind of a stance, right? And I'm not saying people are doing that. I don't know how embodied people are into that idea, right? Like, how are we showing up in ways that we believe these things so that we are permeable in that interaction? One of the things that Bishop Desmond Tutu talks about, let me see if I can pull it up really quick. One of his things is this idea of Ubuntu. And so like one of his core principles in his moral theology or his reconciliation theology is the idea of Ubuntu. And so Ubuntu is like defined as persons are ends in themselves only through the discovery of who they are in others.
Yes.
So let me read that again, right? Persons are ends in themselves only through the discovery of who they are in others. And man, I mean, in that framework, there is no escape, right? It's the eternal invitation that cannot be escaped at all.
It just makes me think, and it doesn't have to be, we don't, every conversation doesn't have to lead to a direction as far as intervention or innovations. It just makes me think, like, what can we do better within our trainings, in our conversations, within, formal, informal, of just promoting this reality. And again, not weaponizing it,
Yeah, yeah,
because I
yeah.
think that's, that my mind, it's so funny. Like, as soon as I go to say this, it's like, oh, someone's going to take this video, and a grace, love, and compassion,
Right,
grace, love,
right.
and compassion. Everybody's, hey, you know what we're going to do? We're going to make sure everybody goes through these specific trainings. We're going to weaponize, connect to the spirituality. And it just is like, I don't know, man. Like, that,
Well,
yeah.
I think it's hard work, right? I think these insights that, I mean, you know, Archbishop Desmond Tutu is discovering this as he is fighting
Hmm,
intense pressures in South Africa,
hmm,
right? Like, and so it's out of that pain this kind of develops, right? Like, and the Ubuntu is not his idea. It's actually deeply embedded in the cultures in South Africa. And so it's this idea that what we think of as we are interconnected, what MLK said, in a single garment of destiny, right?
hmm.
Like, so injustice anywhere is a threat to justice everywhere, right? And so we don't, our frames of training, our frames of thinking around developing healthcare professionals are a counter to that idea, because I think it serves a purpose and function, but I think our mistake might be leaving it there to mature further without any interruption of that,
Okay.
right?
Well said.
We know that, I mean, data shows, right? Empathy declines in medical students as they go through training.
I told in the MI trade I was doing for the medical residents and stuff, I was like, listen, I have not actually read this study or
Right.
these studies. It's like, I get told, it's like, you guys just seem like you're less compassionate by the time you graduate. It is an interesting thing. It is a very
Yeah.
interesting. Yeah.
And I would imagine the same thing for us as behavioral health professionals. I want to turn the mirror on ourselves a little bit too,
Amen.
right?
Amen.
Because the key drivers of what makes psychotherapy work, which is the common factors, which is our ability to be present, the ability to reflect, the ability to connect, help people feel safe. That I don't know how much of that remains embodied as we go through training and graduate out of our training programs, right?
And Deepu, sorry for interrupting you. Um, it's so prevalent. We're not aware at all that it's occurring. And what's so interesting is, like, I'm just coming off of interviewing for our doctoral internship and applicants,
Mm,
right? And it's a great time to get
mm,
the thing, though. I always leave. It's like, oh my gosh, like, it's still about symptoms, pathology, diagnosing what's wrong with this human.
yeah,
How can I fix them? How can I, and again, and here comes that visceral reaction of saying, like, well, again, we're not going to throw that completely out. We need to have evidence-based medicine. And you're 100% right. Like, we do this at a field, even though we don't like to admit it. We'll throw
yeah,
shade at medical. It's like, oh, what are you
yeah,
guys
all
doing
of
in your
them.
training? We do this.
We do this.
We do this.
Yeah, yeah. And so I don't know. I don't know how to engineer against that. And the other thing I think about is like anything that is like deeply transformational. I think there has to be a certain agency in everybody to approach that transformation, right? So I don't know if we can, I mean, this is something you and I and Bridget have thought about thinking further. So maybe something will come up with something. Yeah, I don't know the answer to that, man. Like how to engineer that. Because a lot of what you and I are talking about is, even if we watch our visceral reactions to things that we're seeing, there's a deep somatic sense of where that you can point to your body where you feel that, right?
Mm,
There's a
mm,
cognitive affective synthesis that's occurring
mm,
um in real time, right? And that synthesis drives what we say and do.
mm, mm,
Um, and I don't know how to get at that. And I'm sure I mean, in the spiritual world, like in spiritual direction and other things, they do talk a lot about the ability to do that, right? Like
mm,
I think a lot of people imagine at least like older forms of theology just being written out of like this, just they're very smart people and just writing these crazy things, crazy and like crazy good things. But actually, it was these people who are deeply, deeply committed to the spiritual habits of life, right? Like deeply immersed the in the unknowing of God, right? And so part of that reality that they live in is like this thing that we relate to and that we worship and we are in relationship with. There's no way I can ever know this. Like that's a limitation
mm,
that I cannot touch eternal knowledge because I just can't, right? I can never know the mind of God. So there's like they're already humbled when they begin to think through very complex and deep questions. So they're already
mm,
coming to the writing pad saying, I don't know. Right. And
mm,
so then
mm,
their practices and their interactions with people and all of that begins to shape and convert into theological frameworks and other things over time. So I think that's why I keep coming back to what is your
mm,
stance? What is your sense of embodiment? How do you titrate your somatic awareness into your treatment interactions, inside and outside of a consult, right? It doesn't end when you enter and leave the room. It also, that titration can do enough to disrupt relational frames that others are carrying around you in the medical
mm,
team. Yeah, you need to prioritize probably this diagnosis. And could you also hold them to be creative, resourceful, and whole while they have this diagnosis, right?
hell yeah,
So,
dude.
yeah.
Let me end with this last question. Is there anything right now, and maybe more of a actual pragmatic, tangible thing that you do throughout your day, uh, a practice, a meditation, an activity that allows a stimulus control to keep, seeing humans this way of this belief, any spirituality kind of movement that you're doing right now? Uh,
Yeah, I mean, so there is this thing in like the old rule of Saint Benedict. They talk about this rule of life, right? And the rule of life, it's not a legalistic thing. The metaphor is like it's more like a trellis that allows you to grow. And
hmm,
a rule of life, it's like routine things that you do to stay in relationship with you, others, God, and creation, right? Like that's
hmm,
one way of like framing it. And you should change your rule of life if it ain't working for you, right? If it's not
hmm.
working for you, then it's not a good rule, right?
There you go. There you go. If it doesn't have to function, if it's not meeting the
Yeah.
truth criteria. Yeah, yeah.
So one of the things that I have been mindful about, so I revised it like a week ago, because I hadn't touched it for months. So I just don't want to, I failed at it miserably. So I revised it like a week ago. And one of the things I have in there is to remember to be love and wholehearted in all my professional interactions.
Hmm,
And um and so and love and wholehearted are kind of like values that I like did this exercise for a while and kind of wrote about it and all of that, right? So that just makes sense to me. I don't want to make it sound like I have it figured out. It'll probably change next year, right? Like something else might come up. So I think that's something that's been active with me for the past week. I can tell you I did it like 10 times, and not like it's not, I could only do it 10 times in the last 2 weeks or so. But that's just the 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 challenge of being human, right? Like
hmm, hmm.
try, attempt, learn.
Hell yeah, dude. I love that. As always, man, I could talk for you. And this is what we'll get a weekend
Yeah, yeah.
here shortly to be on the books. But man, my gratitude again.
Thank you, dude.
for this conversation. I don't know, man. There's just a lot of love, and
Mm,
we miss you, and it's always good to be able to catch up. And obviously, for people that are watching, email with questions or let
yeah.
know people's thoughts. Deepu, I'll give it to you. Any final thoughts? Any places your mind goes right now, your spirit goes?
I would end with what we ended when you guys were here as our training, right? Like if you're doing your job right, and think about what this might mean for you, your task is to return people to themselves. And in that process, we are returning us to ourselves, right? And just rest on the idea that uh, persons are ends in themselves only through the discovery of who they are in others,
Hmm.
and let that soak into your clinical frameworks and practices.
I forgot to call attention to that. That's the second time you use that word, soak. I love that. Of allow that to soak in, to seep in.
And
That's
see, then it's the only
I
way.
love it.
It's the
That's
only
it.
way.
That's it. All right, my man. Till next time. I'm sure we're gonna have you on in a couple weeks again. So, all right, everybody.